Good evening, everyone. My name is Rituja Campbell, and I'm founder of Basic Surgery. Welcome to our trauma webinar. We have the fantastic Professor Khan from Brighton Sussex University Hospitals Trust doing our webinar tonight. Before we start, I just want to give a couple of tips and heads up on the technical points of our webinar. If you do have any tech issues, whether you're watching on Zoom or via YouTube, just let us know by using the chat function below. We are going to have a Q&A tonight, and that will be done by Mentimeter. So if you do have a smartphone ready, you can just scan the QR code as we go through the webinar to answer our questions. And finally, we'll have a Q&A session at the end of the webinar. So if you do have any questions to ask, use the chat function or the Q&A function on Zoom or YouTube, and I can put the questions to Prof. Khan at the end of the webinar. So without further ado, shall we start, Prof. Khan?
Thank you, Rituja. Good evening, everyone. Welcome. I'm just going to have a quick shot of caffeine before we start. Thank you for taking the time out this evening and joining us on this really, really interesting series of lectures. Now, I'm going to go through a number of slides, okay? And hopefully you'll have an interesting talk. If you take anything away from it, great. If you don't take anything away from it, well, you've wasted an hour of your life, haven't you? But hopefully it won't be too bad. So we're going to start off talking about trauma surgery. That's my name, and it looks like we're sponsored by the MDU. Now, Hall of Trauma Surgery, for all of those who love Game of Thrones. I love this picture. Everything we do in trauma surgery can be based around this one picture. Some may say that all surgeons are like Drogon, big, fire-breathing monsters. Some are. I'm just not that big. I'm actually relatively short, but hey-ho, we can't win them all. Now, I'm going to give you a few seconds to read through this. I'm looking at point 2 where it says participation is entirely voluntary. You may exit at any time. I'll just be extremely offended if you do. No pressure. Happy? I think you've all read that. And remember, the quiz will be done on Mentimeter. Learning outcomes. I've left this slide intentionally blank. For some of you, there will be no learning outcomes. You're just sat there shooting the breeze, just, enjoying yourselves. Whereas others, you'll have a whole list of learning outcomes. If there's one thing I want you to take away from this, is just an overall appreciation that trauma surgery is very, very simple. We just do the basics very well. That's all you have to take away from this. And hopefully I'll give you some key facts along the way. So the general aims of the webinar are basically to increase your confidence in the management of surgical patients and surgical presentations. Remember, nothing we do in medicine or surgery is complicated. If you stick to the basics, you instigate them well, and you manage a patient appropriately, 99 times out of 100, the patient will do fine, okay? And that's what we try and teach you to take care of, is the common stuff. People always turn around to me and say, how do I manage operatively a high-grade liver injury? I went, you don't. You'll probably see one of those every decade. What you do manage better is learning how to take a spleen out, which happens maybe every other week in some centers. We're also going to increase your knowledge of anatomy, surgical assessment, management, and surgical principles as I talk through the slides. I'll try and do the last one. Let's say, well, you'll be assured you're definitely educated, and hopefully all of you will become future surgeons. Disclosures, I have to do this, okay? I was in the Navy for nearly 2 decades, but none of these views have anything to do with the Royal Navy, Ministry of Defense, Imperial College, Brighton. These are all my views. So if you've got to blame anybody, blame me. These are going to be the interactive multiple choice questions. There's 6 questions. I'm going to show you them at the beginning and then obviously at the end, and we'll figure out if you have learned anything. And these are really, really taxing questions, okay? And Rituja, do I need to keep them on for a few seconds? Do I, each one? Yep, okay. So the first question. This is really demanding. The clue may be in what I'm wearing. There is method to my madness. All of this will make sense at the end of the presentation. And when I talk about hemorrhage grading here, I'm talking about the tennis scoring method, 0 to 15, 15 to 30, 30 to 40, and greater than 40, okay? Great. Now we've got through, I think we got through all 6 of them. Yep. So this was a great quote, which I sort of like nicked off a person who existed a few years before I did, Hippocrates. I mean, I'm old, but I'm not that old. And in those days, bizarrely, apparently only males could become doctors. I didn't quite like that idea. So we came along with this quote: he who wishes to be a surgeon must first go to war. Because as we all know, the biggest, most significant advances that ever occur in medicine or surgery happen in times of conflict, because that is where the impetus occurs and where the drive occurs to actually improve survival, I will cynically say, for political gains. And this is another quote which I want you to take home from today. The more you sweat in peace, the less you bleed in war. This is applicable to all jobs in life. The more you practice, the more you prepare yourself in times when there is not much stress. When you are encountering that stress, things become easier. Take, for example, you're doing trauma surgery, okay? If you know how to expose a vessel, how to rapidly get access into a cavity, if you do that in an elective setting regularly, when it comes to somebody bleeding to death, you know exactly what maneuvers to do. You've got the muscle memory, you've got the mental map, you go in there and you do it. Make sense? Good. So what is a surgeon? I love this one, okay? People think of surgeons are really dumb creatures who just wield knives, cut things up, and then stitch them back together. But you know what? We're actually a physician who knows quite a lot about tissue planes. We know a fair bit of medicine, although we hate to admit it. And we do know a lot about disease processes and pathology. I'm just going to go through a variety of definitions here because the vast majority of you who have logged on are aspiring surgeons. So as well as this being a talk on what is trauma surgery, key components, key facts about trauma surgery, I want to tell you what it is to actually be a surgeon. So general surgery, okay, this is an old term for the generic general surgeon, which unfortunately no longer exists unless you happen to be a pediatric surgeon, in which case they deal with everything. And it's a surgical specialty that focuses on all of the squidgy bits inside your belly. Best way to describe it, because everything we poke goes squidge. So your esophagus, your stomach, small bowel, colon, liver, pancreas, gallbladder, bile ducts, and in some cases, thyroid gland, and even rarer cases, the adrenals. So that is what we deem the term general surgery. Now, this is a new upcoming profession, okay? It is called acute care surgery or the emergency general surgeon, which we're adopting from the States. Now, in order for you to be an acute care surgeon, you need to be able to deal with all of the emergencies associated with elective practice, i.e. all the way from the mouth down to the anus, the esophagus, all the way down to the dentate line. Every single hollow viscous tube which occurs along there, you are meant to be able to deal with. Okay, and in order for you to be able to deal with it, you need exposure to it in elective practice, and you need enough exposure to the emergent practice to be able to let you deal with everything. So you can already see the training length is quite long. And remember, a lot of this work is taken out of hours. So it's not really for those folk who want to have an 8 till 5, Monday to Friday lifestyle, which is what I look for. That is my Shangri-La. So how did I train? Well, I went to this place. I still think it looks the same, although I have not been back there since I graduated, which was a couple of years ago. So I went to medical school, I joined the Navy, and I said, you know what? I want to do surgery. And then a few years later, I became one. I did my higher surgical training up in Yorkshire, which is fairly near where I'm from. I'm from Lincolnshire, which borders on Yorkshire, but nobody wants to do surgical training in Scunthorpe, for God's sake. I hardly ever want to live here. And then once I'd finished my basic surgical and higher surgical training, in my last 2 years, I went to Camp Bastion, where I was there as the registrar or the SR for just over 2 months, where I got a lot of operative exposure. Now, there is no point going to these high workload areas if you do not know how to operate. So I'd got my FRCS, I knew how to operate, I knew how to do emergency general surgery, but I'd very little exposure to trauma or military surgery. I remember just going to Camp Bastion does not make you a trauma surgeon. We're a military surgeon, general surgeon, who's done the relevant training in that setup to deploy there, okay? But a trauma surgeon is a whole separate kettle of fish. So I came back from there, was home for, I think, 4 weeks. And I went to the R. Adams Cowley Shock Trauma Center in Baltimore for a year, which was quite busy. They take in just under 10,000 trauma cases a year. And they have a 13-bay recess, which doubles up to 26 bays at the weekend. And when I was there, they had 4 operating rooms dedicated to trauma. And you, as the fellow, were in charge of the entire acute take. There was no emergency department. You ran the emergency department, you ran the operating theatre, and your colleagues who happened to be surgeons, physicians, emergency department personnel ran the ICUs. So you and your co-fellows, i.e. 12 of you, ran the entire hospital, which was a bespoke 100-bed hospital. So you can imagine the exposure you got. And as I said, we didn't do anything fancy there. What we did do was just do the basics well. You do the basics well, patients survive. You try do something fancy, I can guarantee you there is not going to be a good outcome. So that's what it looks like. Great place, Baltimore. Fantastic crab cakes. And as long as you walk around with a hoodie and a slight limp, nobody bothers you. Apparently, I fit the mold quite well. So this is one of the, remember, a couple of notes here. Time is the enemy in traumatic hemorrhage, okay? What kills patients is not getting definitive control. Now, if somebody's bleeding to death on the road in front of you, bleeding from their arm, what will you do? Will you go in there and say, do not be alarmed, I'm medically trained, I'm securing your airway? No, you probably won't do that. What you'll probably do is say, try not to panic, I'm just going to put some pressure on the wound, and if the pressure doesn't stop it, you'll try and put a tourniquet or something to prevent them bleeding to death. Now imagine somebody's got non-compressible torso hemorrhage, i.e. bleeding into their chest, their belly, pelvis, or into one of their long bones. It's very, very difficult to compress that. So up until you have got control of that bleeding point, you cannot resuscitate a patient. You cannot resuscitate a hemorrhaging patient. You need to turn off the tap. And we'll come more into that in a bit later on. Now, this is the lethal triad, okay? Down at the bottom, acidosis, hypothermia, coagulation. And into that, you can add in hyperkalemia and hypocalcemia. They all fit in together. With the acidosis, you get hyperkalemia. With the coagulopathy and the hypothermia and the increased volume replacement, you get hypocalcemia. So what happens? You damage a blood vessel. Blood vessel bleeds, okay? Funny enough. You're losing the central heating circulatory fluid, which transports heat around your body. You're also losing a fluid which contains all of your clotting factors. Now, if you're losing your clotting factors, you're becoming coagulopathic. If you're losing volume, you're not perfusing your end organs at all, because remember, the whole purpose of your blood, see, I told you we know a bit about physiology, is to take that oxygen molecule from the atmosphere and deliver it to tissue. That's what you're trying to do. So if you've got not enough blood, you're not delivering enough oxygen there. If you're losing blood, you're peripherally going vasoconstricted. So you're still not delivering that oxygen molecule there. And therefore, you are not undertaking aerobic respiration. You're undertaking anaerobic respiration. Where you have 38 ATP generated, you're only producing what, 4? So when the byproduct of aerobic respiration is ATP and heat. If you are not producing heat, you're not warming up the blood. So your central heating system is failing. Everyone with me so far? So if you're losing all of this stuff, you're becoming hypothermic because you're not generating enough heat. Your coagulation cascade and your enzymes love the temperature being 36 to 36.5. If it's not that, they sort of like go and strike. So you're losing blood, you're losing temperature, you're losing coagulation factors. All of this renders you to become hypothermic. Your enzymes aren't working because you're hypothermic and you've lost the coagulation. So you can see how that circle goes round and round. And what you have to do to prevent this all happening, you turn off the tap. It ain't rocket science. I'm just a plumber. I can just access bleeding vessels quite quickly and use God's given hemostat, i.e. my hand, to stop anything from bleeding on most things. Most trauma surgeons can stop surgical bleeding. It's the non-surgical bleeding which is directly attributable to this death triad, which is the problem. And in the good old days of ATLS, and by the way, ATLS, it isn't advanced, it's basic trauma life support. It's just that some people don't like doing courses with the word basic in them, so we have to put advanced in, makes us feel special. What they used to do was give lots of people crystalloid. Remember, that's a bad thing. It may be an MCQ question in a bit. So crystalloid is bad for you, okay? Because what is the oxygen carrying capacity of normal saline? How many coagulation factors does normal saline have in it? Nothing. And the other thing, what you have to do is the acidosis, as I said, is related to the hyperkalemia. As you're correcting the acidosis, the hyperkalemia will hopefully correct, but also give the patient as much calcium as you can pump into them, because it is a positive inotropic agent and it also helps with enzymatic function. Takes you back to that lovely cycles you used to do in first and second MB, if that is still a thing. I'm pretty sure people still do first and second year exams. I'm looking at Rituja's face as a representation of 130 heads out there.
I was nodding.
Yes, that's what I mean, I guess. So this is classical hemorrhagic shock. You're gonna love this, okay? I've even color coordinated it for everybody. So you've got the grade 1, 2, 3, 4 down at the bottom, where grade 1 corresponds to 0 to 15, grade 2 corresponds to 15 to 30, grade 3 corresponds to 30 to 40, and grade 4 corresponds to over 40% blood loss. Okay, this is what happens to your heart rate. Look, it's in red because it's blood related. This is what happens to your blood pressure. It's in a maroon. I didn't want to get two colors to confuse you folk. And guess what yellow is? Come on, you can do this. Urine, well done. I could hear the vibes through the laptop. In reality, this is what, oh, sorry, let's go back. So we'll go back to this in the questions. Who believes that this is how hemorrhage occurs? It doesn't at all. This is really good in laboratories if you're operating on pigs. Humans have some things in common with pig physiology, but not this. Remember, these experiments were done in the 90s and 70s on pigs, on controlled hemorrhage, not people who have polytrauma, when they have a massive concurrent systemic inflammatory response syndrome. In reality, this is what happens. If you have a young person, they compensate really, really well. And you know what they will say to you? They'll say to you, Doc, I don't feel well. I think I'm gonna, and just like that, they'll collapse, because what happens is their adrenergic system, their catecholamines, they will squeeze all of their peripheries to within an ounce of, their death, and then they will shut everything down. This is what happens to them. They compensate really, really well. So the best time to stop hemorrhage is right at the beginning, okay? Right at the top. If you can see my arrow, if you imagine this as a runaway train, it's easy to stop the train at the beginning. It's very hard to stop the train towards the cliff, okay? You have an actual burden of injury where if you don't get them before they exceed that, the patient will actually die. They may be talking to you, but the patient will be dead. So what are the key points to take away? There is an overlap between hemorrhage control and sepsis control philosophies. And what I say about this is, lesson to take away, especially from the hemorrhage, if somebody's bleeding to death, if somebody's bleeding intra-abdominally, what you do is you put a cross clamp on the descending thoracic aorta, you put a cross clamp on the supraceliac abdominal aorta to control bleeding. Am I correct? You do that very quickly. If somebody's got sepsis going on, we'll say, you know what, you've got a perforated appendix. We'll put you on the operating list and you can go in there as and when required. Remember, although they're not hemorrhaging, they're actively leaking fluid out of their blood circulatory system into their surrounding interstitial fluid. So they are actually suffering from hypovolemia, and we don't address it as quickly as we should.
I've got a question, Prof. Khan. Is that
Yeah,
all right? So we've got a question saying, how do you recognize internal bleeding? First stage.
Brilliant. Great question. How do you recognize internal? Two things: physiological parameters and the eyeball test. If somebody looks to your eyes that they're really unwell, chances are they are going to be unwell, okay? Also, look at the physiological signs. And thank you, whoever raised that point. I'll just go back a couple of slides to this slide here. This is very pertinent where pediatrics are involved. Pediatric patients will have normal physiological signs. They will look clinically okay. However, you determine their degree of resuscitation by feeling the temperature on their arms. So as they perfuse more distally, you know you're resuscitating them. My normal answer to that question, and I do get asked that question a lot, is assume everybody is sick. If you're thinking somebody's bleeding to death and you work them up as they're bleeding to death, you've lost nothing. Okay, over triage. If, however, you fail to escalate in the back of your mind saying, actually, this person's actually fine, they're okay, you'll miss the boat. So my advice to you is always treat every patient as though they are sick until you prove that they're well. Don't let the patient prove they're well. You have to prove that they're well by excluding everything, okay? Do your can I go to bed at night test. If you have done everything and you can leave the hospital knowing you've done right, that is the best thing I can advise you on. Because you know what? You have to live with yourself. I have to do that every time. Hence why I'm slightly OCD. So a very good question, but a general rule of thumb, physiology, clinical findings, and assume they're sick. I hope that answers the question. This is where Game of Thrones comes in, okay? So that scene with Dragon, what was he doing? Blowing up ships and putting things on fire. Well, that's what we do in trauma surgery, okay? We stop the floods, i.e. turn off all the bleeding, and we put out all the fires. We stop all the contamination by sewing up the bowel edges and all that lot. And remember, when we do trauma surgery, we are not operating to anatomy, we're operating to the patient's physiology. So what we will do is we will go in there, we will do the basics of what is required, so the anaesthetists and the critical care guys and girls can sort the patients out. And the best way to think about this is, if you're in a time of war, you're in a warship and the ship has been hit, there are floods going on, there's fire. How many war movies have you seen where the injured ship goes, right, I'm tagging myself out, I'm off back to port, please leave me alone, I'll come back when I'm all fixed up? That never happens. So what you require is, while the surgeon is sorting out the floods and the fires, the anaesthetist and the intensivist are continuing the attack to restore physiology. It's a team sport trauma, okay? You know, no person is an island. You have to work together as a team to make these patients live. And when I operate, there is no blood-brain barrier. The actual drape is down so I can see the whites of the anesthetist's eye and the monitor, and we can constantly communicate. Anesthetist will tell me if they're keeping up, if they're giving enough blood. I'm telling them if there's surgical non-surgical bleeding going on, and you literally try and keep the patient on the table for the minimum time possible. And this has been allowed to happen more nowadays because we don't use crystalloid. We use targeted resuscitation. We use the one-to-one-to-one. However, just telling you now, if you lose 1 unit of packed red cells to replace the physiological function, you need to give 2 units of packed red cells, 2 units of FFP, and 10 units of pooled platelet. So for 500 ml of blood loss, you're already needing to replace with 2.5 liters to get back there. That is why there is a vogue now to use whole blood. And in one of the places in Afghanistan, working with the Afghan surgeons under an American flag, I did give fresh whole blood back to transfuse to a casualty, and it's like human super glue. You give fresh whole blood to somebody, their bleeding just stops, because remember, the fractionated blood products we have got so many chemicals in, the way the filtration happens, we're probably losing chemicals and substances in there which we don't even know about. So when you're transferring fresh whole blood, you're taking that blood straight from one person into another with minimum additives. So in reality, yeah, that's what happens. Somebody bleeding to death, you stop the bleeding. In the sepsis patient who is still losing fluid, just not hemorrhaging, what do? We'll give them antibiotics. We'll get to them in a few hours. Remember, the only thing that has shown to improve survival in sepsis is time to source control. Giving antibiotics isn't source control. It's giving domestos or a Band-Aid, as the Americans would call it. So the general surgeon, master of all trades, jack of none. Well, it's a bit hard to be, isn't it? I mean, I'll be honest with you. I go into work every single day and I learn something new, and never will I say I'm a master of all trades. The reason why I keep going in this job is I learn something new every day, and hopefully I pass that message on to other individuals, just like I learn from others as well. It's a continuing learning specialty, and be wary of any surgeon who calls themselves an expert. That's where problems start. Everyone okay? Everybody eating their doner kebabs, KFCs and stuff? Brilliant. My cup of tea is getting cold, but I'm still drinking the same one. I love ancient quotes, okay, because there is actually so much truth to them. We don't rise to the level of our expectations, we fall to the level of our training. This goes back to the previous quote as well. The more you sweat in peace, the less you bleed in war. If you have put the hours in, if you know what you're doing, the patients will be looked after. And when you're absolutely knackered and you're hanging, what you will fall back on is your basic principles and your safe training. So you fall back to the level of your training. If you have not been trained well, you will not fall back on your training well. Whereas if you've done the basics, your consultants, your registrars have taught you how to operate, how to look after a sick patient, how to escalate, you know what, you can just fall back on that on autopilot and the patient will still be looked after. So what's the current general surgical curriculum? How can you train to do trauma surgery well? You can do esophagogastric, hepatopancreaticobiliary, colorectal. I avoid colorectal. Vascular. Some may say vascular is a technique, not a specialty. I'm just putting that out there for my vascular surgical colleagues. Breast surgery, thyroid, minimally invasive surgery now, okay? If you go to some parts of America, all what they'll do is they'll just be laparoscopic surgeons. Any complications that occur, they'll go to acute care surgery, or they'll become surgeonc. They'll only do cancer operations, nothing else. That is their whole practice. It's really hard to become a general surgeon nowadays. And do you know why? Because it no longer exists. Everybody has to declare a subspecialty. I want to be a right inguinal hernia surgeon, because the left ones, there are some sliding ones which occur, which I'm not really a fan of. So how can we mitigate against this, okay? How can you get the training you want to become a trauma surgeon? Well, you can do trauma surgery fellowships, okay? You can do emergency general surgery fellowships. You can join the military, join humanitarian organizations. But I will tell you one thing you cannot teach anyone, and that is common sense. Each one of those specialties relies falling back on basic surgical principles. That's all you have to do. Don't do anything groundbreaking. All any of these things teach you how to do is just do the basics well. Obviously, in different intensities. Trauma surgery, hemorrhage control is time critical. Military surgery, you're working obviously on humanitarian surgery in conflict zones where there may be a risk to your life and health. Emergency general surgery just occurs out of hours, same with trauma surgery. So you can see all of these things are stressful for different reasons, but you still have to have surgical skills. And surgical skills just isn't operating, it is actual clinical assessment, perioperative management, and making sure the patient achieves near enough their pre-injury, pre-insult status. I'll tell you a quick story. When I was a junior registrar, I used to be really proud of myself and going, God, I've just done this operation. High fives all around theatre. I've never seen any surgical programs, but I assume it looked like something from Scrubs where you're high-fiving everyone. And then you realize, you know, that's false bravado, because patients will literally try and ruin your day every single day of the week, because you know what complications do happen. In trauma surgery, morbidity is part and package of what we do. A negative laparotomy carries a 40% morbidity. That's if you find nothing wrong in the belly, carries a 40% morbidity. Now you add in doing operative intervention on somebody who's already sick, you can see the morbidity you can get. So I'm in my old age where I've lost more hairs than I've gone white from. I am only ever happy when the patient has been discharged, they're many months down the line, and they've nearly resumed activities they were doing before they got unwell. And then you can actually think, you know what, maybe I did something right, okay? All surgery is very humbling, very, very quickly, okay? Patients put their lives in your hands, okay? It is a massive responsibility to take on, to operate on an individual, because they're putting their life in your hands. They have total trust in what you're doing. So just as a take-home method, you know, when I said learning objectives, just remember, don't celebrate too early, okay? Because medicine has a habit of biting you in the ass. And just look after their patients as if they were one of your own. When you're operating on them, I'll be honest with you, I block that out. You can't think of an individual as a patient, especially if they've got severe injuries. Just target the bleeding points, target that. You have plenty of time to reflect afterwards. And every single patient that you will operate on in trauma surgery, elective surgery, a part of them you will carry with you for the rest of your life, okay? And yeah, it is one of those specialties where, yeah, if you catch my drift. So what is trauma surgery? Blimmin' hell. Just read that. I'm not going to read all that out. I think I'm losing my voice. Okay. It's basically an out-of-hours specialty where patients come into you really, really unwell. And you think, this is where you think, why didn't I just become an accountant? Or some other daytime specialty? Nothing against my accountant colleagues and friends. What is acute care surgery? Well, remember, I'm hoping that you're getting the idea now that surgery just isn't operating. It is looking after a patient through a whole spectrum of modalities, from point of injury, pre-operative, because only when you know where a patient has come from do you know how to actually manage them and how to plan discharge. Yeah, military surgery, humanitarian surgery, a whole separate kettle of fish, because when you come back to normal civilian practice, you're no longer worried that, oh, you know, CPOD list is really overbooked. Oh, we haven't got enough staff. Well, you know what? It ain't that bad. No one's trying to kill you. Maybe the canteen. But apart from that, you know. So how does the UK train emergency surgeons? Okay, I'll be honest with you. Okay, the last 2 decades of conflict, especially since the horrific events of 9/11, we have been involved in conflict every single year. Yeah, every single year for the last 2 decades. And what's happened is what we have learnt in war, we've brought back to civilian practice. Our American colleagues normally follow a few years behind us. I hope some of them are watching. TXA is amazing and we teach you a lot of stuff, but that's my plug to them overdone. What we've done is incorporate the wealth of knowledge we have learnt in war, brought it back into civilian practice, but then our civilian practice has so rapidly expanded where actually it's a synergistic relationship now. So how did we used to get exposure for trauma? We used to go to war. We used to go to fellowships overseas. However, times change and so do we. How do you, as F1s, F2s, core trainees, junior regis, how do you get to do trauma surgery? Well, you know what? It's a specialty which spans your entire training. You get introduced to it right at the beginning, especially if you work at a major trauma center. You still may be introduced to it at trauma units, which do take a considerable number of trauma patients who are eligible to get into MTCs. But what you do, and this is the best part about it, is in order for you to do trauma surgery, you need to be a good elective surgeon. So when somebody says to me, oh, I'm really interested in trauma, how do I go about it? My first thing is, well, have you done any research? Because if you're asking me that question, you probably haven't read anything yet. But the key answer to that is, do your membership, do your ATLS, do your CRISP, go through your entire surgical training and become a good surgeon. Become a surgeon who can get exposure, who can actually manage an acute general surgical on-call, deal with the common things, and then also towards the end, you will then undertake a specialist fellowship or get exposure, once you can use the knives and forks, on how to manage these patients operatively. Because I'll be honest with you, up until my trainees can prove to me that they can do elective operating well, if a patient is hemorrhaging to death in front of me, they will not be dealing with that because it's a skill set you need to build on. Remember, time is of vital importance. You need to turn off the tap to prevent the deadly triad. And also, beware, you may have some anesthetists who turn around and say, don't worry, I can keep up with that amount of blood loss going on. Nonsense. For every unit of blood you transfuse in the first 24 hours, you independently increase the risk of the patient dying. So the key thing is turn off the tap and get the right amount of blood products in them. Don't waste blood products, okay? Because it is an organ transplant you're giving them. You wouldn't just randomly go giving somebody a liver for abnormal LFTs, would you? Same thing with bleeding. Stop the bleeding. Oh, there we are. It's almost I knew what was coming up in the next slide. So to become a good general surgeon, and it's not just operative skills, perioperative skills are important, and also communication. Okay? Just be a good human being and speak to everybody as if, you know, everybody in that operating room is your equal. Everybody brings in a certain skill set. Leave everything at the door and make sure humility comes in with you. You get a lot more things done by being nice to people than being a dick. It's an 18 plus, isn't it? So I'm okay. I can say that. No children, apart from my son, may be watching this later. Oh, well. and good teamwork required as well. You're only as good as your weakest link. And the more you practice with your team, the better you get. Remember, the more you sweat in peace, the less you bleed in war. Just go away with that mantra. Just get doing the elective things correctly, become a well-oiled machine, and everything will work. And how do you maintain these skills? Well, if you want to be a trauma surgeon, go work in a trauma center, okay? If you want to be an emergency general surgeon, go work at a busy DGH. I mean, seriously, the amount of operative workload I got at a busy DGH dwarfs what you get in teaching hospitals. And remember, the key thing is always to keep your mind going. Operative skills, once you've learned them, it's a technical skill. You seldom forget them. What actually does wear down is your thought processes and the mental maps. Always think about how you're going to manage patients. Keep going through scenarios in your head, because no two trauma patients are the same. And never listen to anybody who said, oh, well, when I had this trauma patient in the past, oh, I did this and that worked. Yeah, that may be great anecdotal stuff, but every single patient is individual. No two trauma patients are the same. And this is what happens at the end. You get the final product. You have your training. You have that philosophy in saying, how do I make myself better? How do I work with others? How do we drive this thing forward? And then you get the exposure. You become that acute care and trauma surgeon. So what helped me? My God, joining the Navy back in, God, I did my interview in 97. And these were the posters that were out then, okay? This may be part of another question. And this massively raised Navy recruitment. So you can see it. Feared by his enemies, adored by the nation, trained by the Royal Navy. Well, I was for 20 years, worked in there, but I didn't become Bond. I got the same rank, slightly better uniform, but yeah, he got all the other stuff. The Aston Martin specifically. Now we are going to go and tackle some of these MCQs. I think I've given you the answers to most of them. I may talk you through them. I'm getting shakes of my head. Okay. So what is my favorite color? Have they answered this already, or do they need to answer it again, Rituja?
They need to answer it again.
Okay. So what's my favorite color? God, what color is the ocean, I wonder? Hey. Come on, I've just shown you this slide. Well, now I'm a veteran. I tell you what, 1, 3, and 4 are wrong. Love of chocolate should be correct, because I just love chocolate, especially dark chocolate. It's good fun. So how does hemorrhage grading correlate with clinical findings? I think I made my opinion on this very clear with the urine, blood, and blood pressure slide. Oh, and just as an aside, I hate silent theatres. God, seriously, silent theatres, the bane of my life. Music has to be playing in the background, just at a normal level, just to keep the beast calm. Excellent. Hopefully everyone got that correct. With this slide, make a decision, make an incision. If you've made the wrong decision, go change it. Indecision kills. We call that cerebral masturbation. It's the bane of everything, okay? Just make a decision and do something. Just pontificating is bad. I think I've answered that one as well, haven't I? Learning outcomes covered. Hopefully it won't be a blank slide like this. Hopefully you've taken something away that has given you an insight in what's involved in trauma surgery, maybe a dabble of military surgery, and just generally managing the sick patient. That's my email address. If anybody has any questions, please feel free to ping that to me.
Fantastic. Thank you, Prof. Khan. We do have a couple of questions, if that's all right.
Well, well done to two of you who stayed awake.
The first one that I've got is, I've heard you saying that it's essential that basic skills are done well. What do you consider as basic skills in surgery? And also, can you give a few examples of basic skills that should be practiced throughout medical school for someone who's determined to become a surgeon?
Great question. Basic skills start off with, just common decency, be polite to patients, be polite to people around you. As I said, it's not just operative skills. People think when I talk about basic surgical skills, it's just operating. It is actually your interaction with colleagues, your interaction with staff. It's also clinical assessment. Only by seeing lots of sick patients, lots of patients, will you improve your clinical acumen. Now, surgery specific techniques, you know what? Learning how to handle tissues, getting into the right tissue planes, knowing how to hold a needle, how to actually suture. People turn around to me and say, I can suture. I tell you what, I retrain people very, very quickly. All of those kind of things are the basic surgical skills, is just break everything down into their basics from interactions, assessment, and also technical skills. Does that make sense?
Yeah, thank you. And then the second question we've got is, so as a trauma surgeon, are you predominantly involved in the abdomen, leaving limbs to ortho, neck to ENT, so on and so forth, or do you get involved everywhere?
Very good question. No, I do. Well, I've been trained as a trauma surgeon. I do all my own chest. I do all my own belly. I do the vast majority of my own vascular. The bone stuff, well, no bone stuff immediately kills you. Remember, a fracture is a crack in the bone associated with significant tissue, soft tissue damage. So the break in the bone itself won't kill you per se. It's the surrounding damage. So what I tend to do is just control the bleeding and then let ortho and people with the skill set to deal with what they're used to.
Great. So that is all for our MCQs and our question and answer session for today. I just want to say a massive thank you to Prof. Khan for doing this webinar. And for those who are watching, we've got a couple of questions about the post-course questionnaire coming up. So yes, you need to fill that in to receive your certificate of attendance. The questionnaire is actually going to come up on your screen when you complete the webinar, so not to worry. And if you do miss it, then you'll get an email in about a day's time with the link to that questionnaire as well. So once again, thank you very much, Prof. Khan. That was excellent.
Thank you.
Would you mind if we went to the next slide?
Oh God, yes, sorry, there is another. There we are.
There we are. So this is our next webinar, and that will be at 7:30 next Wednesday. So this is going to be our orthopaedics webinar, and it's going to be presented by Mr. Simon Fleming, who is an orthopaedic registrar, and we'll be covering making referrals to orthopaedics, emergency orthopaedic presentations, and common post-operative orthopaedic complications. So I'm just going to leave the QR code on the screen there for those who want to register, but you're also going to get the link in your questionnaire and an email that's going to be sent to you soon. All right, well, fantastic. Thank you so much, Prof. Khan. And thanks to everyone for coming to the webinar.